other state STD directors or HIV STD directors on if there's any strategies other states are using, if they have any other protocols that they're willing to share on how to address this issue. I also have with me John Creviston. He's our syphilis elimination coordinator here in the state of Illinois, and he deals with a lot of the situations where there's multiple syphilis infections with MSM. And did you want to give him just a kind of an example?
Well, you know, this is the hello everybody. This is the time of the year when we're all doing our annual progress report. And as I was entering cases, I was putting in more cases. I was seeing just a startling trend of co-infected MSM, some who have had syphilis infections, early syphilis infections, primary, secondary, early latent, several times a year. We also have some that, I just by name I can recognize them because I've been here about 10 years, and there are clients that are infected at least once, twice, every single year with stage syphilis. And Rich and I talked about this because it's a concern from a public health standpoint, but and I said, what kind of messages are we not getting to folks, or what are we doing wrong? What can we do better in order to stop the spread of these syphilis infections? And I'm speaking specifically about syphilis, so I know several of these individuals were also co-infected multiple times with gonorrhea and chlamydia as well.
Thanks, John. One of the things Bill Smith at NCSD did is actually put me in touch with Dan Wohlfeiler, and that's how the call came about. And Dan actually has authored several articles on this topic, and after reading them, I realized it's a much more complicated situation than I realized. So that's kind of a summary for me and for the state of Illinois. I'm really interested in talking with other state HIV STD directors on how they're dealing with this situation, if they can give us any helpful hints on how to handle the situation and do some good public health. Thank you.
Dan, feel free to jump in.
Okay, I'm jumping in. Good morning, everybody, or good afternoon for those of you east of the Rockies. I just want to also thank Dana and Rich and John for putting this call together. And I'm going to talk really briefly about some of the issues that we're wrestling with and that I expect others are wrestling with, and as well as propose a couple of solutions. As a big caveat, I do policy and communications. I've never been a DIS, but I've spoken to some of our folks here, and I think the same frustration that Rich has talked about, our DIS also faced. I also just want to start with a little bit of data. There's a paper which I can ask Dana to send out or post on the web that Stephanie Cohn, who was here for some years, and Rylene co-authored, that looked at the numbers about repeat syphilis among MSM here in California. And the mean number of MSM who had a primary syphilis and repeat infection within 2 years of their initial infection was just about 6%. And again, that's the mean. That doesn't account for those who would be sort of the most frequent flyers, if you will, who have more repeat infections. But it is important to think about those data to start out with. That said, one of the things we know is that a small minority of men who get infected repeatedly and who have a great deal of risk behavior can have an impact far beyond their numbers on the epidemic through their mixing and having sex with people who just have a little bit of risk behavior or less. Secondly, I just want to put on the table that our efforts to reduce people's sexual risk are really, it's hard to do that well, and it's particularly hard to do when we're talking about people with a great deal of risk and reduce the number of their unprotected partnerships as much as we would like to. And I know our DIS have really wrestled with what's the right balance of how much emphasis they should be putting on reducing sexual risk versus how much should they be, increasing the level of testing. There are, up to now we've been saying throughout the country that people should get tested at, 3 to 6 months, depending on their risk behavior. There is and I believe most people are using the 6-month interval. We've had some discussions about how could we be putting out a message and be promoting testing that would be more frequent for those people who are having a lot of unprotected partnerships. And out of those discussions have come 2 efforts, both based out of Seattle. One is a website that's called findyourfrequency.com. And what they're trying to do is invite men to go online, enter a little bit about their risk behavior, and there's an algorithm in the program that then generates an answer saying you should get tested with this frequency or that frequency. And I think one thing that we're trying to grapple with is if you're having 1 or 2 incidents of unprotected sex, whether that's oral or anal, you might want to get tested as every 6 months. But if you're having 50 partners in a 6-month period, that level of testing probably isn't going to do enough to protect them from an STD or protect their partners from an STD. Okay. Secondly, there's a paper that's in draft form and not yet ready for prime time, also coming out of University of Washington, that is looking at what would be the impact of that kind of increased testing. And I think the gist that I've gotten of the message of the paper is that it could have a positive impact on reducing transmission. And once that's out, we can have more discussions about that. Last, I just want to talk about a meeting which some of you have heard about in different presentations that we had now 10 years ago, where we brought people who specialized in network modeling to think about what would the implications for practice be. And what they said that particularly applied to gay men and other MSM was that we needed to focus on 2 things. One is how do we reduce concurrency, and 2, how do we help people become better shoppers when they're looking for sexual partners and have them have the most and help empower them with the most information they can have about their partnerships. A couple of those concepts particularly apply to the venues where we know MSM are going to meet partners, and the 2 primary venues that make sense to talk about in this context are bathhouses and sex clubs and online dating and hookup sites. It's interesting that there was data out of Chicago a long time ago that looked at repeat syphilis cases and found a higher correlation with bathhouse attendance than with other venues, and that shouldn't be too surprising to us. Also, interestingly, bathhouses are where guys have the least information about their partners other than, height, age, race. Very little other information is exchanged. Online, we know that guys can exchange a lot more information, and one of the important, one is about HIV status, and 2, it's about what risk behavior people prefer. So, for example, there's fields on many websites which are related to, yes, I'm looking for safe sex. Yes, I'm looking for no P&P, no meth use, wild sex, or no party and play. There's also, some of them have, when was your last HIV test? Can't remember any sites offhand that have when was your last STD test. We did do a survey, which I know a lot of you have heard about, where we asked website owners, website users, and STD and HIV directors. Many of you probably entered your data into the survey and collaborated, and thank you for that. And what we found was that all 3 of those groups really supported having fields about looking for safe sex or not, and all of them supported having a test site, a widget or a link to findstdtest.org where people can find out where to get tested. We also found a lot of support for, and this gets back to the frequency of testing, for getting reminders related to getting reminders to get tested. And the way we phrased it was, do you want a reminder at an interval that you can choose to get tested? And I think there's a lot of promise there. So we're trying to set up a work group of STD and HIV directors to work in a much more coordinated way with some of the website owners. And I know a couple of them have expressed interest in collaborating. We've got others who have stayed pretty silent, and we really do need to follow up with them. So I'm going to stop there, and I think, Dana, you're going to be facilitating a discussion with questions and answers and looking at what we can do.
Thanks, Dan. So Dan just did the perfect segue. Folks on the line, questions, comments, initial questions or comments for Rich or Dan?
Or each other, I would hope.
I don't have any questions, but I do have some comments. Can you hear me?
Yes, and feel free to identify yourself.
Okay. My name is Andrea, and I'm in Corpus Christi, Texas. I'm the clinic program manager down here for the STD HIV clinic. And one of the things, I've worked in some different states, and one of the things that was different in two of the states, when someone was newly diagnosed as a brand new HIV positive case, one of the states had a form that they signed that day acknowledging, my HIV status and, to tell my partners and, to tell any medical people taking care of me to wear condoms, things like that. And they actually signed this form. And here, I'm in Texas right now, and we call it recalcitrant counseling. And basically, we don't do it when they're a brand new positive, but if they're a positive from even 10 years ago and then they come up with syphilis or gonorrhea, chlamydia, we then bring out this form. It's kind of the same thing. It acknowledges, I understand, my HIV status, and, I'm going to tell my partners, I'm going to wear condoms. And so there's two different ways you can do that. Now, as far as how it works and what the outcome might be, every single district is different, and it depends on the health authorities. I've been, again, in the different places where somebody, when we sit down and each time they come back with a new STD, they re-sign this form. And now some of the DIS ask, well, okay, this guy's signed it 5 times, nothing's happening. Well, that leads us to go to a health authority, and we can say, listen, here's the situation, and in different states, different regions, it's possible. I know there was a case in Amarillo, Texas, several years ago. It was a prostitute, a known positive, and they gave her the option, because she had a substance abuse problem, of jail or rehab. So they worked with her to try to get her help and try to get her to understand, that she was harming herself also. So those are two different ways of kind of attacking it with this form, or dealing with it. I'm sorry, I don't like the word attacking. Trying to get people to acknowledge, yes, my HIV status. As far as other things you guys hit on, I know I heavily rely, because I'm a small program, and I rely on my CBOs for testing. And that's one thing I would urge everybody across the nation, is if we can get our CBOs to possibly have their staff draw blood for syphilis also, instead of just doing like an oral HIV test, a rapid test. That would, I know, help the DIS world immensely, and of course disease intervention, because we'll catch more syphilis cases, because as most of you probably know, syphilis is up by huge percentages. Another thing that I've personally done here in my area is I've been putting out fax blasts through the AMA to the physicians, and it's regarding, one of mine regarded syphilis, and it talked about reporting guidelines, it talked about symptoms and treatment. Another one I sent out was about gonorrhea treatment, because I was finding that people were not treating properly, and then just talking a lot. It's a big project and it takes a lot of time, but I personally deal with as many providers as I can. As a matter of fact, right before this phone call, I had a provider, a guy walked in, had an RPR 1 to 2, well, they bicked him. No confirmatory, no referral, no nothing. Well, after this phone call, actually the guy's already here because I explained to him, listen, if we have the ability to do a confirmatory, we need to really know, do you have syphilis or not? Because at this point, I don't even know if he has it or not because the confirmatory was never done. And what I'm getting to with this story is I've already spent about 30 minutes with that provider explaining how necessary it is to run that confirmatory before they start bicking everybody. As far as the locations, here in Corpus, it's a lot of the Grindr, the geographical finder apps, and you're right, they don't know their partners very well, so it's impossible for us to find them because they don't exchange phone numbers. But I've given my spill on a whole bunch of different things, so I'll shut up.
Thanks, Andrew. I think that was all some great information, too.
This is Daniel Pohl. I'm the Director of HIV STI Prevention at Howard Brown Health Center in Chicago. And I want to say that I'm glad that you brought up the role of community-based organizations in trying to, regardless of whether we're talking about disparities that we see among folks that are young or by race, ethnicity, or by sexual orientation or gender identity, I think it's so important to increase the capacity of community-based organizations where community members feel comfortable going for services, to be able to empower them, get them trained, and help them to provide these services in the most culturally competent way that's possible. But I think the other thing that I'll say is that the form that you mentioned, I find to be a little insulting. And I know that that's probably not how it's meant, but when you're talking about a community, if we're talking about men who have sex with men, gay and bisexual men, that is so disproportionately affected by these infections, and it feels like unfairly targeted through, it's hard for me not to get kind of a little worked up, and I'm trying not to. But I don't think that that's an effective tool at helping men navigate disparities in risk that exist among networks of sex partners that they would normally choose. And I certainly think that there are cases where it makes sense to do something a little bit outside of the ordinary. Like if you do have a person that just repeated infections over and over and over and over, especially if they're dealing with mental illness or substance use and abuse, to think about approaching that a little differently. But I think the threat of law enforcement or jail is not a good approach. And to be honest, the first thing that I think about when I saw that this call was happening was the first thing that I always say to people that I talk to, in about 93% of the cases that we have here at our health center or MSM, the first thing I say is, I'm so glad you're in the revolving door, because what that means is that you're accessing care. And I worry more about people who we don't see coming to our health centers, either because they don't feel comfortable going or they don't have access or whatever it might be. If we're finding repeat infections among groups of people, it means that they are receiving care. They're going in to have stuff addressed. Maybe they are recognizing symptoms, or they're going in when they're told about exposure directly by a sex partner or by an employee of a health department or CBO. So I think it's also good to reframe how we look at it. Those are my 2 cents.
Can anyone hear me?
We can hear you.
Okay, awesome. I kept trying to speak and I was muted and I couldn't unmute myself. This is Dawn Diorio-Ricas, and I always have an opinion, which is why it's important for me to be able to speak. And hello, Rich. And thank you, and it's nice to talk to you. And I wish I could say we're not having the problem and you're keeping it all on your side of the border, but that's not happening. So we are seeing the same thing in Marion County, which is the Indianapolis area, and it's where we have almost all of our syphilis cases in Indiana, and especially, and it's like 70% MSM, and about half of those have HIV. And we started noticing it was kind of like it's been creeping up over the last couple of years, and so, Rich, you might be seeing the same thing in your data. We didn't seem to see this problem with repeat syphilis as often as we have noticed this past year. So when we looked back, and we actually just finished doing this exercise, so this call is really timely. When we look back over the last 5 years, you could see a gradual increase. 5 years ago, gosh, we only had, 2 guys who had syphilis before, and then, up and up and up and up to the point where I think cumulatively it looks like we have, I want to say maybe 30 cases of repeat syphilis, and that's repeat between 2 infections, and I think the highest number we had was 5 syphilis infections that were repeated. And so we had the same questions and concerns as you do about, what's going on here, and how are we failing, and what can we do better to try to get through to these guys that they're putting themselves at really dreadful risk, not to mention that they might be transmitting things to others. And so we started very informally, I wish we had done it more as a research project or something, but that would have taken IRB and years and probably, money we don't have. So we started trying to interview these guys again with the purpose of asking them how we can better help. Like basically, what's up? What's happening in your life or your circumstances or around these infections that is causing these repeats, and is there any way we can help? And I don't have an answer for you, and I guess that's probably the most depressing thing, is that we haven't arrived at any great conclusions or solutions yet, because we seem to be getting the answers of, I know what I'm doing, yeah, I know this is risky, this is my choice, there's nothing you can do to help. So that's my 2 cents.
Hey, this is Rich again. Daniel, I'd like you to address how you handle clients that come back with multiple infections. Do you refer to mental health? Do you recommend increased screening for these clients? Is there anything that you're doing at Howard Brown that you think is making an impact on behavior change, or do you think people can change their behaviors, or do you think, maybe quarterly STI screening for clients that are high risk is something that will work for you? I was kind of wanting to follow up with you on that discussion. Thank you.
I don't know if there's like a one-size-fits-all, because I think, with some of these guys, it's like a phase in their life that they go through. They're like, gosh, this is really a drag to keep having to get these shots, and then they come out of it, or they get into a more steady partnership, or there's a problem with substance use and abuse, or mental health and depression, or something like that. And then other folks, it seems almost like what Dawn was saying, almost like a preference of the type of sex that I want to be having is inherently risky. And we've had some clients here. I was managed our DIS program for 8 years, and at this point, like, there's not a lot of names that come up that I'm like, oh yeah, I've talked to that guy a couple times. Oh yeah, I've run him as a P1 5 times. So I mean, it's just kind of the norm, unfortunately, here. And so, but I can't approach this work in a way that feels like I'm taking care of people if I first demonize them or their behavior. And I think that even though I want everyone to take care of themselves so that they live long, happy, healthy, productive lives, that's just not the reality of where some people find themselves right now. And I don't want them to feel judged or like they're coming to a place that is going to think badly of their decisions, because people do have the right to make their own informed choices. And I do think a lot of this is being driven among men that are serosorting with other guys that are positive, which is in some ways good and in some other ways bad. But yeah, I don't know if I answered your question, but.
I just want to say I love Daniel. I love your thought, and I will pass it on to the DIS about what you said about this. What we're seeing might be a phase in that person's life. I think that's so very positive, and and wonderful, rather than, because we see a little slice of their life where they're having risky behavior, and it concerns us, and we feel helpless because we want to help, and we're not effective. And I just love, kind of being able to put it in the context. So thank you for that.
No problem.
Aaron Shipman, Nagadate, Colorado Department of Public Health and Environment. Long-time listener, first-time caller. We are here as no managers or section chiefs. We're actually all either DIS here or CRCS providers. So we're the ones that are having to do the interviews and then later on offer the mental health support system in order to try to address this. And just there is a couple things. One is, while education in and of itself and knowledge isn't enough to stop anything, one of the things that I have found with the cases that I've had is a lot of people are really unaware of how syphilis is transmitted. They're thinking it's much more similar to HIV or other diseases. They're not thinking skin to skin. And they have taken to heart lessons like oral sex is less risky. But they don't understand that oral sex is less risky for transmitting HIV, not with syphilis. And so a lot of the individuals we're talking to are reporting condom usage for like penetrative anal sex, but nothing for oral sex, and not realizing that they can get syphilis from that. So that's one little piece. The other, in terms of kind of repeat testers, we are not implementing it here, but the CDC recently released another DEBI called PCC, Personalized Cognitive Counseling, which is specifically designed for gay, bisexual men, men who have sex with men, and it looks at addressing the risk behaviors much, much more specifically. It is very graphic, so if you're not comfortable with that, it can be a difficult discussion to have. But it looks at things in a very realistic picture. So that's one thing. If you haven't seen that or heard of that, it is worth checking out. They don't pay me, but you can find it on effectiveinterventions.org. But I'm going to ask my colleagues to throw out, if they wish, something from their experience, because this is one of the big drivers of the vast majority of our work right now, is syphilis infections and then repeat syphilis infections.
Hey, this is Tom. I'm a DIS. I've been in Colorado for a couple years as a DIS. One of the things I can't help but notice when listening to this conversation is that it seems like a lot of the activities, a lot of the direction of programming is directed towards the client and the client's behavior, which I certainly acknowledge is something that we should do our best to impact and make a change with. But I can't help but wonder if anything can be done in a two-pronged approach in looking at talking to providers. I feel and we know that MSM who are HIV positive make up the bulk of repeat syphilis infections. At least that's the demographic in Colorado. And I can't help but think that we should capitalize on the provider-patient relationship between these ID docs or nurses or whoever's helping them and these guys who are coming in maybe every 3 to 6 months for viral load CD4 or other ancillary services. And so I do wonder if SES funds or anything has been done in other states that have been successful in assisting providers in increasing the amount of screening, talking about the damage that syphilis can do to your body, and not just giving them BIC and sending them out the door, because to a client that says, oh, well, this can be fixed really easily. And, oh, I can come and get a shot. Yeah, it hurt really bad, but, there are worse things. And so I often wonder if, a different approach can be also acknowledged and maybe looked at in looking at one of the other places where we really can capitalize on that relationship. So that's just kind of what I thought.
This is Andrea in Corpus. I'm so glad you just said that. One of the things we do here is we cluster interview every single person that's involved in a case, even if they're negative, even if they're a suspect, an associate. And when I say cluster interview, we sit down every person and we show them the syphilis pictures. We explain, how you get it, all the symptoms, everything. And so they walk out with hopefully a full understanding of how you get it and how you can pass it. And that seems to really, really have helped us out a lot.
Hi, this is Fraser Williams. I'm in California, and I just wanted to talk a little bit about some of the provider stuff that we've done in California. We developed a toolkit, which is currently in revisions and going through approval processes, but it's called stdcheckup.org. If you want to look at the website we have, it's got a provider side as well as a patient side to the website. But we have definitely engaged providers in a number of ways, and a number of local health jurisdictions have done that through developing liaisons with providers, and also noting anytime they see clinical mismanagement that may be occurring, they reach out to providers. And then any high-volume providers get sort of a pre-problem visit or reaching out from DIS to talk with them about their patients and give them resources. And so there's definitely work that's happening here. I know NCSD also put together a brochure that's designed for providers around working with MSM. I think it's focused on MSM of color, but really the material is relevant to MSM in general.
Jessica, thank you for plugging the Optimal Care Checklist. I was going to do that at the next interim. Who else? Comments? Questions?
This is Derek.
Derek?
Sorry about that. This is Derek Monroe from Alaska. I have a couple of points I want to make. First, I want to put out there that I am a gay male, and I haven't really heard anybody say anything about personal responsibility. What role does the gay community play in taking responsibility for the spread of HIV, for the continued spread of syphilis, and for the increase in gonorrhea infections? Because again, we can talk about the provider, we can talk about the patient. It's almost like if you are a man that has sex with men, you get a get out of free jail card. So I'm a little lost on that point.
Anyone have a...
Yeah, this is Nancy Wolf, also from the Colorado Department of Public Health and Environment. I do the comprehensive risk counseling services, and so /DIS work too. And I do appreciate the discussion about wanting to address disclosure, and I also agree that sort of the threat of law enforcement or jail is not effective, and the angle that I take is more about how to appeal to the individual's investment in their community and as a whole, and their interest in just not wanting to infect other people, and just the tools that they use to try to avoid that. And so, here in Colorado, we do offer free risk reduction counseling, and whether it's through our agency or through contracted agencies to help people increase their disclosure skills and the motivation to use them.
This is Dan. Thank you for that comment. I also just want to say that's backed up by data from Australia also, which found it was this curious sort of finding that for most guys, getting syphilis was actually not as big a deal as getting a common cold. It wasn't a big threat to them. It was easily treated, but there was an impact of or a feeling that people were willing to be responsible to other community members, and there was a sense of altruism. Now, I don't know if that data was really broken down by guys who occasionally, have unprotected sex and get syphilis maybe once in their lifetime versus guys who get it frequently. And I suspect that we're dealing with two very different populations that we don't consider enough. And just back to the personal responsibility thing, when we did interviews years ago with guys asking them, asking guys who didn't have unprotected sex why they didn't, one of the most common themes that came up was responsibility, but I actually don't know that we can really take that concept and apply it. I mean, I haven't seen ways to do that terrifically well to people who have, for whatever reasons, a very high level of unprotected sex with partners. It's sort of hard to import that concept from one group to another.
This is Jessica again in California. We in San Diego have a program called We All Test, where people sign up to get regular testing for STDs, and so and about 20% of those people are HIV positive, and so it applies to this call as well. But when we asked people why they signed up, what were the important factors for them in signing up, one of the absolute top factor for people was taking care of the health of their communities. And so I think there's a responsibility factor in there, a sense of personal responsibility in testing behavior, and then that could be something that we could potentially leverage.
Hi, this is Mark Aubin in Washington State.
Go ahead, Mark.
Okay. Thanks, Dan, for mentioning that you find your frequency in Seattle. And they also let the people that are doing that sign up for text messages that will alert them of when they need to go in to get tested again. And so those can be linked to their frequency of how often they need to get tested. And my question for you, Dan, is many of our outbreaks in the past were among serosorting HIV-positive men, and they would tell each other that they were HIV positive. As HIV starts to use treatment as prevention, is there a discussion about saying not only if you're HIV positive, but what your viral load is among men as they're serosorting?
I don't have a lot of data to say one way or another. I do know that you do see online more and more guys who will say, positive but undetectable. But I don't think I couldn't really tell you if that's hit any critical mass of people. I'm just curious, why are you asking?
I think it makes a big difference because, first off, if someone thinks that their viral load is negative, they may not be reticent to tell their partners that they're HIV positive. And then we were seeing a lot of syphilis and gonorrhea only among those that were HIV positive because they weren't using any protection at all. And those that aren't on HAART are, of course, at the highest risk for passing HIV on to others.
Right. I mean, I do note that we've seen a real shift in norms, particularly, with the news that once you're on treatment, you're less infectious. I mean, we have in town here an adult film producer that's actually been marketing not just films between two positive guys, but there's also one that has features unprotected sex between a HIV positive and HIV negative individual. And they were certainly very intrigued by the data that showed, the rates of transmission of HIV, if you have low viral load, are really, really, really small, and probably smaller than many of us in the field realize. But I do think there's a real interesting question about what we do with those norms, and what community response there is to those norms. There's certainly given the lack of threat of syphilis, there's nowhere near the community mobilization that there was, say, 15 years ago, and I think it's unrealistic to expect it. At the same time, you see very little discussion about when, those norms about responsibility or protecting partners are openly flouted, such as through films like that.
This is Aaron Zimmerman again in Colorado. With the viral load kind of correlation, it does lead to higher incidence of unprotected sex. If individuals, well, I have undetectable viral load. Okay, well then we're not going to worry about using condoms. That does definitely come up a lot. But in the bigger picture, a lot of people think that, well, because my viral load is suppressed, I don't need to disclose either, because the chance of me infecting them are low. And I think people mistake the chances are low with no chance at all, and they're quite confused between those two very different things. And so when I try to talk to people about undetectable viral load, we say, yes, we want everyone to obtain this, part of the national strategy. But it's like the airbag in your car. If you're not wearing your seatbelt and you crash your car, the airbag might likely save you, but the little warning sign on your visor says to be used in conjunction with your seatbelt. And so it's the same thing. Obtain a suppressed viral load, but you need to use a barrier protection as well if you really want to make sure that we're not transmitting, and that disclosure is still important because the other individuals should be allowed to have a choice at what risk they are willing to take. So I think that it gets into a very sticky situation. And then additionally, the interplay between other STDs and HIV transmission. If you have said, oh yeah, my viral load suppressed, but the other individual has gonorrhea, the viral load is not one-to-one between blood and semen, there's still a strong possibility of transmission. So I think it's a disservice to people for them to think that just because their viral load is suppressed, they're no longer infectious.
So thank all of you for those comments. So outside of the community and personal responsibility push, who else are doing things to sort of impact or try to make some kind of impact with these clients?
Hi, this is Derek from Alaska. One of the things that we're doing in Alaska for all of our patients that indicate they have sex with men is we try to make sure that we test all the appropriate sites, to include having the patient do a self-collected rectal swab.
Great. Okay.
This is Melissa, also in Alaska. Can you hear me?
We can.
Another thing that we've been able to do, I think because we're a really small program, is to be more nimble with some of our online outreach. Using sites, it's hard, Grindr's kind of a game changer for us, but when we've had outbreaks of HIV and syphilis, which in a very low incidence state like Alaska is kind of a big deal for us, we have a presence online on sites like Adam for Adam, where we actually, we sit online and chat with guys and say, hey, we're doing testing today from, 12 to 5, come by. Did you know there's an outbreak of syphilis going on? And we've gotten really overall very positive feedback from the members on the sites. And we've also identified new cases. People come in and get tested after seeing the messages that we're putting. We've also gone into Craigslist and responded to postings in the casual encounters, usually the men seeking men section. I'll sit on Craigslist and respond to every post for like a 3-day period. And then we also post our own ad on Craigslist saying, HIV outbreak. Unfortunately, Craigslist, they do get complaints, and we get busted because we're not an appropriate posting on Craigslist, apparently. I'm like, yeah, we're the problem. So we get booted off after a while. We can do it for a couple days, and then our posting gets shut down. But encourage health departments to be as tech savvy and as nimble with the internet as your clients. And I'm guessing a lot of health departments are pretty far behind in, getting in touch with folks in the ways that they get in touch with each other.
I just want to put a plug in for the work group and people who might be interested in working on it to have a coordinated approach with some of the website owners. We've had some recent instances where people have been going from different health departments to website owners. Website owners don't understand which requests they should be looking for. And I think your experience with Craigslist isn't at all atypical. So we're trying to improve our coordination with them and get a sense of what they're willing to permit and what they're not, and how to work with them more strategically around partner notification, for example.
This is Emer Smith from the state of Maine, and this is kind of more of a question and maybe a food for thought, but one of the aspects of the National HIV/AIDS strategy is really emphasizing on prevention with positives and comprehensive care for positives. And I'm not sure how many people who are coming in our state who are co-infected with syphilis and HIV actually access care on a regular basis. But I think one of the strategies that we're going to be exploring is a way to re-engage people who have been living with HIV into care as a way to also address co-infection.
Great. Okay, who else? Anyone else? Comments, questions?
I just have a quick question about how, if somebody wants to work with that work group that you plugged about working with the websites, how do they get involved with that?
You tell me your name right now.
Okay. Well, it would be actually somebody I supervise, but we can start with me. My name is Amy, A-M-Y, Busby, B-U-S-B-Y. My email address is my name with a period in the middle at la.gov.
Great. We'll be in touch.
So Dan, how many people are you looking for on this group, and have you met yet? What are the parameters around this?
We don't have any firm parameters. I'd say if we could get a group of 3 or 4 folks in STD and 3 or 4 folks in HIV, we'd be in a really good spot. And we've got a couple, but I think just to have some good discussions and get some coordinated follow-up would be terrific.
What type of time commitment, Dan, are you talking about? This is Rich.
I think a couple hours here and there, probably to start out with a couple hours every month and go from there.
Hi, Dan. This is Johnny Guadalupe from Housing Works in New York City. Is it possible you could share your email address with us so that I can send you my information? I'm from a CBO, by the way.
Yeah, no, I know Housing Works real. My name is so long it's going to take 10 minutes to convey it accurately. Maybe Dana, you can send it to him.
I can.
Great. One, I want to hear from other people also about what you're doing, and 2, I think it'd be nice to have a discussion about, one of NCSC's great roles is they can present a united voice or a series of requests to CDC. Are there research questions or interventions that we want them to focus on? Do we have requests as a group about this issue that we'd want to forward?
This is Rich in Illinois. Maybe a possible research question to address to CDC is, how do you engage MSM into repeat testing or quarterly testing, and does that decrease comorbidity with increased testing?
So is that sort of expanding on the findyourfrequency.com idea, but also looking at what other ways we can do that?
Yeah, I think so.
Okay.
Yeah, I think we really need to kind of seek CDC's help and advice. It doesn't seem like anybody on the phone calls really. We've got a lot of things here and there that we can try, but I think we might need some advice from CDC and some TA.
I'm going to go ahead and plug effectiveinterventions.org yet one more time, since that is the CDC programs of evidence-based effective behavioral interventions designed specifically to address what we're discussing. And again, PCC is a new one that's very good. CRCS is a public health strategy of the CDC to provide additional behavioral interventions. There's also multiple ones on there that are clinic-based and medically-based interventions as well. So it's a good place to start because we might be asking questions that have already been answered.
Yeah, I think that's a great idea. also, I do know from my examination of the literature and a lot of those effectiveinterventions.org slides, there isn't anything right now about frequency of testing. And typically, when the CDC presents its guidelines, it's if you're a gay man, get tested at this frequency. If you're one at high risk, which they define as anybody with a non-monogamous partner, which defines what percentage of us, pretty high. That doesn't really do much. And when I've talked to some people about how do they come up with the testing intervals that they do have, it sounds like it was a good guess, but there wasn't a whole lot of data to back up those numbers. So that's one. Are there other issues that we would want to forward on? I mean, I heard some people talk about what sounded like a need to clarify messages and get some optimal messages about what does low viral load actually mean in terms of infectiousness, and what are the best ways of delivering that in a way that folks can understand and make good use of.
I'm not wondering if, as we're talking and I'm thinking about all this sort of linkage to care and treatment as prevention, it may be a completely new wave of prevention messaging that we need to create, because it's essentially, we're saying if we can get people on treatment, they won't spread HIV, but it's doing nothing for the spread of STDs except probably increasing them. And those messages need to be linked proactively somehow, because I think, the word is out about the viral load. We can try to talk people out of it, but it is the single biggest justification for unprotected sex among HIV-infected people that I ever hear. So somehow I think we need a new STD testing and prevention campaign that relates to treatment of HIV.
I think in conjunction with that is the provider piece as well. This is Jessica in California, because if people are accessing care and keeping their viral loads suppressed, it means they are in care, and ensuring that providers are taking appropriate, sexual histories and risk assessments with their patients, and not assuming that they're, not sexually active or in monogamous relationships. I think that those messages would have to also occur in conjunction with that.
Yeah.
This is Rich in Illinois, and as you guys were just talking, and Dan, maybe you know more of the players down at CDC. I wonder if at in the Center, the HIV and the STD programs have ever partnered on any type of project like this, because it seems to me they're pretty siloed down there, and maybe this is a chance for them to work together.
I haven't heard a lot of crosstalk about how those messages do get integrated across the two centers. What are we calling them? Centers, divisions. And I'd be happy to work with Dana to, maybe several of us could write that letter and say, here's some specific things we could use your help with. I also think that, while it's important to ask the CDC, I don't expect that we're going to get a quick answer out of them on some of these solutions, but at least it points to areas that, these are problems we're facing, and we need your help on it. And I think they'll be responsive to that. Whether they come up with a quick solution is a whole other thing, but I think they can also work with outside researchers to figure out how do we address some of this. I know I've been in this job 14 years. I've seen very, very little written about how to address the issue that we're talking about on this call in terms of the core group or, the folks who are getting reinfected the most. And I think calling it to their attention would be really helpful for all of us.
Barbara Conrad in Maryland. Can you hear me okay?
Yes.
Great, thanks. We recently, in January and February of this year, had an EpiAid project conducted on site in Baltimore City Health Department, and it was originated out of the HIV surveillance in Atlanta when they looked at some data from a few years ago showing a high proportion of HIV and African American MSM, and they wanted to look into that more. And as the Maryland State, as the host agency, and Baltimore City Health Department worked with this EpiAid project, we ended up recommending and then helping them to focus on syphilis reinfection in HIV-positive MSM. They'll be reporting on that in probably late 2013 in an MMWR. So I know that they seemed quite surprised at what they were seeing. Now these are I can't think of the name of it for now. They're EIS officers, so that they aren't necessarily coming into it with a long history in either STI or HIV. But still, they were, very intrigued and interested to see, patterns similar to what we've been talking about here today. So they're certainly taking back, very energetic and enthusiastic awareness of this as an issue. So that will get some CDC attention of that method later this year. Another thing is that here in Maryland, we've been doing some work over the past couple of years that we need to do a lot more around the concept of routine STI screening as part of routine HIV care.
Yep.
Trying to promote routine and STI screening with frequency tied to risk factors as something more than just syphilis testing, more than just the annual syphilis test that is recommended under Ryan White or wherever that standard is. And then certainly back to what somebody else mentioned about making sure that every site that needs to be considered is tested. So recommending extragenital testing and having that just as part of overall health and making sure that it's not just HIV health that is considered, but overall sexual health. But that is something that could definitely benefit from large national messaging to healthcare systems.
Okay. Go ahead.
Sorry, I know it's getting late, but this is Daniel, and it strikes me as a lot of the studies of these kind of repeat infections offenders, sometimes they get called, are very descriptive. Like, what are some things that we can correlate with repeat infection? And the person mentioned the effective behavioral interventions, which is great, but I don't know that there's ever been a study of what type of intervention that is nuanced or different or tailored for this specific subgroup of people, if we're talking about HIV-positive MSM in urban areas, et cetera, what type of intervention might be effective at helping them to either reduce their risk, get tested more often, or to avoid reinfection. And so a prospective study of an intervention might be warranted if we think that this is something we're seeing more of and will continue to see more of, which I hate to say I think is probably the case.
Yeah, DCC really is the one that did look at that more closely. And so if you're a fan of heart, cover your ears. But for example, the clients who come in, it was specifically designed for gay men and pretty much gay identified men who are either getting repeat STIs, whether they're living with HIV or not. So they're at high risk in HIV. And it's a different type of counseling where you do a sexual inventory that basically goes, when I put my partner's cock in my mouth, and it kind of goes on from there, on and on and on. So you're talking about cock, you're talking about ass, you're talking about fucking, what people do. And it uses that language specifically because that was what was shown to be much more effective instead of dancing around it, pretending to be, nice, clean clinical settings. And it uses that to then explore one of the more recent risk events that took place, the reason they came into the clinic, either for that positive test, that contact, or whatever it was that brought them back in, to then really start looking and taking it apart to see, okay, so where in that situation, because, a situation will probably happen again, but where in that chain of events would it work for you as an individual to break that chain? And then it uses a combination of motivational interviewing, other cognitive behavioral techniques to try to help that individual develop what will be that person's effective plan for the next time that comes up. So that is why I've mentioned that one several times. And again, why that one's worth looking at, because it's designed specifically for that, people who are coming back or having multiple infections, and to really address the reasons why, So that's why I put that one out there.
Hi, this is Johnny Guadalupe again from New York City with Housing Works. I just wanted to go back to the quick discussion around involving community-based organization and just my experience here working at Housing Works and now working together with the New York City Department of Health, where they have, we started a syphilis campaign targeting MSMs here in Brooklyn and in New York City. And also one of the things that's worked with us is teaming up with the DOH and actually being able to provide free screenings at no cost to the community, meaning that folks could come in. We have medical assistants and phlebotomists. They can draw the blood, and the lab work will be at no one's cost. And the New York City Department of Health has actually helped us with that. So that's really helped us as a community-based organization to reach out to this community where the numbers of syphilis are pretty high. And in just 1 month, we've had a few reactive RPRs. And just going back and forth with the DOH in New York City and getting assistance around education, and they're actually going to be coming to Brooklyn, to our East New York site, to do a training to the staff, non-clinical staff, more around syphilis and what it means to have a reactive RPR and a history of syphilis, so that we're able to actually go out to the community and do more education and get more folks tested. So I just wanted to share some of the stuff that's Housing Works, the CBO, is doing with the DOH here in New York City.
Great, thank you. I do think this has been a great call, and I think we probably need to have a part 2 of this call moving forward, especially as Dan's group comes together and we think more about interventions and different language and messaging that we might want to use. And I just want to echo what I heard Jessica say a couple of times and several others. I really do think that a huge component of this is getting and retaining people in care and also engaging providers and making sure that providers are doing those routine risk assessments and talking with their clients about the levels of risk and testing. So that's just one part. I know we have our part and the client has their part as well, but I think they're all working together. We can probably get something done, but I know it's going to take a lot of work, and we're here at the initial discussions. Any last comments from anyone? A burning thing that you have to say before we release you all from the call?
This is Melissa in Alaska, and I just wanted to chime in about Ryan White-funded clinics and the need. Really, they have standards of care clinically on how often they're supposed to screen people for things like TB and syphilis. And what we really need to do is get those things changed so that they are required to do it more frequently than once a year. If we really want to impact how often folks are getting screened, I think working within those Ryan White-funded clinics is a place to start.
Great. Thanks, Melissa. Okay. Well, thank you so much. You'll get an email right after this, an evaluation. I'll also send out Dan's contact information. Thank you all.
Thanks, Dana, so much. Thanks, everybody.
All right. Have a great one. Bye-bye.
Thanks.
Thank you. Please stand by.